You know, many times I see students, residents, sometimes even clinicians memorizing sensitivity, specificity for exams or mainly for clinical practice purposes, but very few of those people understand what those numbers mean when I ask them about it, especially when we're standing in front of a patient. So understanding a diagnostic test is not about memorization, it's about knowing whether a test can rule a disease in or out when the clinical decisions matter. This topic on sensitivity specificity is part of our diagnostic test series. It's part of a larger collection of topics on the area of evidence-based medicine and specifically biostatistics. And those things can be found over at This Is Why. And with that, I'm Dr. Busti, your host. And at This Is Why, our goal is to help healthcare professionals transform their medical knowledge from what to why. Because when you know why you do what you do in the proper context of the evidence, it changes the how, and that changes everything about the patient-oriented decisions that we're all going to have to make every day, especially in the diagnostic process. So our series is broken down into part 1, which is really about that phase before the study starts, our statistical analysis plan. Okay. Part 2 represents our summary statistics. That includes descriptive and inferential statistics. And then part 3, which is where we're at right now in the overall series, we are focused in on the diagnostic tests, specifically sensitivity and specificity, where it's really about the test performance. Okay. Now you see that these topics can all stand alone, or they can be done in a particular order. We have provided that order and what I think is the best way to try to interact with the content. But you can do them in any order that you want. But I will make references to other lectures that are available over on YouTube and our podcast channels. Now, we need to start off by talking about the gold standard test. And the reason that's the case is because a new test that we're going to study or analyze has to be compared to something, right? And so before we evaluate a diagnostic test that's new, we have to understand the baseline or diagnostic, sometimes called the gold standard or reference standard test. How good is it? What are its issues? How is it done? All those kind of things. The clinical reality is this. Gold standard tests, even though we call them the gold standard or reference test, are rarely themselves 100% perfect. They can be difficult to obtain. They can be invasive, cost lots of money, expose people to things like radiation, so they can be expensive. Okay? They can pose a risk to the patient. The take-home point is the accuracy, okay, which is the tests that you're looking at, sensitivity and specificity is entirely dependent on the quality of that gold standard or reference test that we're comparing it to, okay? Because if the new test is better, you'll see here in a minute, we could generate false positives, okay? And so that becomes something important that we're wrestling with, especially as we develop maybe a potential new gold standard or reference test. So let's talk a little bit about the calculation and then begin to move into the interpretation application. And what does it mean? You're going to see this 2x2 table if you haven't already seen it before, over and over again. I'm going to dive into the individual cells right now, but I wanted you to see this is the basic skeleton. And these abbreviations, true positives for TP, false positive for FP, all those things, they become part of the equations. And you have to understand the math, right? And what box those represent. If you set up your rows and your columns correctly, it sort of makes sense. So let's dive into that first. True positives. So over on the left, the rows represent the diagnostic test in question. So let's just say it's a new one, because we're going to be reading a study about it. There's the disease known by the gold standard or the reference standard, and those represent your columns. So you have the positive and negatives in both rows and columns. And so when you have a diagnostic test that says, hey, it's positive for the disease, and the disease by the gold standard says, yes, it's positive, then that is obviously a true positive. That is the correct identification of the disease, and it supports further action and treatment. But if the test says, hey, it's positive, but the gold standard says it's negative, it could be a false positive. Could be. And I say could because, again, it goes back to the performance of the gold standard. It's possible that the new test over here on the row is better than the gold standard. So it could be a false positive, but really accurate. So that could be a false alarm. It could be harmful in real life, obviously. Creates some anxiety to people. They get labeled with a diagnosis. It can cause more testing, which raises cost. You label the patient. They now have a diagnosis. We call patients with diabetes diabetics, right? And so you get on life insurance policies, medical insurance policies, it creates problems for them. What about the test that says it's negative, but the gold standard says it's positive? Well, that would be a false negative, and that could be a missed disease where we have created harm to the patient because we're delaying the diagnosis, which then would delay the appropriate treatment and lead to worse outcomes. Think about sepsis. All right, you don't identify the surge criteria early enough and you delay care. Well, we know patients with bacteremia going on to, having manifestations of sepsis, their outcomes can be very bad with time. And so we treat it as a medical emergency and we initiate treatment acutely. Same thing with acute ischemic strokes. Time-sensitive treatment matters. And then lastly, when the test result is negative, and the gold standard says it's negative, that is a true negative. That means you have correctly ruled out the disease. So these are the two boxes that you want to be in. But when you do an analysis, if you're the researcher or you're reading the paper, you should be able to create, or they should show you a 2x2 with the information. And then you have some additional calculations that you need to do that drive all of these things. And I want to come back to this because the abbreviations TP, FP, TN, FN, those things become very important in the calculation. And I'm not saying my way is the best way, but this is a way that I've tried to keep it straight in my head, okay? So if it's helpful to you, keep listening, right? If not, maybe it's just another way of looking at it, all right? But it helped me to avoid mistakes, especially when it comes to board exams, when you're expected to calculate these values and then interpret them. This is the core structure of the formulas for sensitivity and specificity. Now you see that there's a line with a space. Obviously something needs to go in that space. Well, it's either an N or a P, okay? And I always got them, initially when I was learning this, I got it always confused. I couldn't keep it all straight in my head. So I'm going to walk you through a way that you can remember that. I'm not saying it's perfect. I'm not saying it's the only way. It's just the way that's worked for me, and I've taught it over the years. And the feedback that I have received is that it was helpful to other people, especially when you're undergoing some anxiety or on a board exam or a test, and you're trying to make sure that you calculate this right. Because if you calculate it wrong, your orientation is wrong from then on. Now, the other thing that this method can be helpful for is at the bedside or in the clinical environment when we're talking amongst students and residents and fellows and things like that. We're discussing things. In my head, if I have that main skeleton memorized, all I have to know is really one spot if I'm talking about sensitivity or specificity. So now we're going to talk about the calculations, and let me orient you to these various formulas. We have sensitivity up here with the letter N That is consistent with the N for negative predictive value. I've made them blue. There's no P's there, okay, in sensitivity. Specificity over here is in red font, if you will, and has no N in it, just the letter P. And again, it becomes relevant in the formula. And again, positive predictive value, the first letter is P, obviously. Now, that matters because let's look at sensitivity. Sensitivity has an N, there's no P. So the very first part of the formula that you would fill in is right here with the F. So the N is the location of what's next to the F. And then that means the other letters are their exact opposite. That was the way I could remember it and keep it straight in my head. Sensitivity had that N right there in the bottom corner. Specificity has the P in the right bottom corner, right here, okay? And so it was a visual, helpful reminder for me when I was nervous, stressed out on those exams, or when I was starting to use that at the bedside or in clinical practice, and I was really trying to think about it. I had a skeleton of that formula in my head. And so then the other letters just become the opposite, okay? Same thing with positive predictive value. The P is there, and so all the letters are P in that formula, okay? Negative predictive value, all of the letters are N. So those are small rules. I'm not saying, it's like a mnemonic, right? You got to memorize the mnemonic, what it means, what it says, in order for it to work. Well, that's same thing here, but if that helps you to keep it straight in your head, then use it. But here's where I think it can be helpful as we start diving into interpretation. When you change a number in these formulas, it influences obviously the answer, right? So you have a numerator and then a denominator. As the denominator increases by usually false negatives or false positives, that will decrease the number because a larger bottom number or denominator with a smaller numerator is going to result in a smaller number and reduce it. So we don't want false anything, do we? The perfect test with 100% sensitivity will have a 0 false negative. There is nothing there. Okay, and so then the numerator and the denominator are the same number. It is 1 or 100%. So anytime the sensitivity is less than 1 or 100%, it's because there are false negatives. It's just math. If you have that framework in your head and you understand that basic concept, it will carry you a long way in interpretation. It will also start to make sense of this seesaw thing that I'm going to talk about a little bit later. So let's now step into a little bit of that interpretation. You have the formula. You know how to remember it. But remember, what does it mean? A board exam will many times ask you language that is here on this slide. That sometimes is the answer or the way you interpret it. But remember, sensitivity, it helps you to determine the ability of a test to detect the presence of a disease when it's actually present. That's why you have a true positives in that formula. You do not want false negatives. So the other way you could say that is the proportion of all patients with a disease and also test positive. You want that number to be as high as possible, so that the sensitivity is 100% and there's no false negatives. So when we think about a test that has good sensitivity, guys, this is about helping us to rule out a disease. Because if you rule it out and you have a 100% sensitive test and it's negative, then there are no false negatives with this test. You've ruled it out. So sensitivity, another way that some people teach this, and I was taught, is that sensitivity rules out, SNOUT, SN, sensitivity, the N, no P, out, SNOUT. It's just a way to remember it. It helps you with the formula. It helps you remember what is its purpose. Okay. Now consider, again, the closer to 1 that you get, the better the sensitivity, which means that there are less or fewer false negatives. Okay. And I've already said that. So that's really important. Now, what about specificity? The P. So we know that FP down at the bottom, the numerator. So if there's false positives, it's going to lower my specificity. This is determining the ability of a test, okay, to reliably detect the absence. So remember, the TN is true negative divided by the true negative plus the false positive. So it's the ability of a test to detect the absence of a disease when the patient actually does not have it. Another way of saying it again, same thing, the proportion of all patients without a disease who also test negative. The reason I put both of those definitions or interpretations, if you will, in there is because board exams love that crap. And I call it crap because it makes your head spin a little bit. So if you have to stop and rewind and just, or stare at that text or re-listen to it again, you need to get your mind wrapped around it. And you need to be able to look at it from slightly different angles using different words that say the same thing. I'm sorry, I don't make up the rules. I think it's cruel that we do some of these things to ourselves and for board exams, but they're trying to make sure that you understand the concept, aren't they? Not that you've memorized something. That doesn't mean you understand it. So just like sensitivity is about ruling out, SNOUT, specificity, is about ruling in. So the SP and the N is spin. So you have spin and SNOUT. And again, hopefully that helps you to keep these two terms about the performance of a test in their framework and what they mean. So the closer to 1 or 100% you get, the fewer false positives that a test is going to have. Okay? So again, if you just simply look at the math, I'm driving this concept home. You have a numerator and denominator, and if something reduces the sensitivity, not that I want to do that, it's because most cases you have false negatives. So in this example, 10 divided by, and it's just an example for math purposes, 10 divided by 10 plus 5. So 5 is our false negative rate. You get a sensitivity of 0.67 or 67%. But if I raise my false negative rate from 5 to 7, right, then my numbers change. And my sensitivity goes from 0.67 to 0.56 in that case. Okay? And so the problem with that is that you have more false negatives. Let's walk through an example. Now, I have given you, in this example, sample data. There's no reference on here. It's just to demonstrate the concept, because if you understand the concept, you can do any of these moving forward. So you have a 2x2, which is, I filled in the blanks. They have to give you that data for that test. And they have to give you the data for the gold standard results. Okay? And so you just simply place them, the true positives in the true positive box, the false negative in the false negative box, the false positive in the false positive box, and the true negative in the true negative box. That's why you need to know the basic structure of the 2x2. Now you see that I've added a total column on the far right and also a total for the rows on the bottom. And so you should then add those up, and what you see, right, are those numbers added up. And then if you go across, you'll see that 100 plus 100 equals 200. And the column's going down. 110 plus 90 is 200. That should match up. That's how you can test the reliability of your own 2x2 and that it's saying what it's supposed to say. Okay? But now that you have the results from the test, a study that was done, you can now calculate the sensitivity, specificity. You can also calculate that test's accuracy. Right? So remember, we talked in another lecture on precision and accuracy of a test result. The accuracy is the trueness. How true is it to be positive when it needs to be? This test that we're evaluating. And so when you go down and you look at that formula, remember, you have the structure of the skeleton of there's the T divided by the T plus F. And all you have to do is fill in the blanks. And if I'm calculating sensitivity, it's the column down in the positive from the disease. Okay? You just fill in the numbers. The true positive is 90 divided by 90 plus, we had 10 false negatives. So the bottom number becomes 100 divided, and then top number is 90. So the denominator is larger. So we know that sensitivity is less than 1. You do the math and you see that it's 0.9. So the sensitivity for this new test being used is 90%. Okay? Now we'll talk about the interpretation here in a second. Okay? But you can almost see that there because there were 10 away from the 100, so it should match up in your head. So what is the clinical translation? The so what? What do I do with that? Right? So our sensitivity was 0.9 or 90%, and that means that a test with a sensitivity of 90% will help you as a clinician identify that 90 out of 100 people will have that disease. Now, another way of saying that or observations is that the sensitivity is not 100%. That means that 10% of people are actually have the disease, will have a false negative result. And so that take-home point is that the higher the sensitivity, the fewer the false negatives you have. But that's how you use the numbers. That's what it means when you're talking to somebody. Because no test, for the most part, is perfect. Now let's go to the specificity. That's the second column, right? And that second column uses the false positives and the true negatives. And again, you just have the same skeleton, T divided by T plus F. But remember, the letters are different, the other second letter. So because it's specificity, the FP, right, is a false positive rate. And so you have 80 divided by 80 plus 20. So it's, again, 80 divided by 100. And that gets you 80%, which interestingly also matches up with the true negative. Okay? So these are just checks and balances of how you use and interact with this data for its own accuracy and reliability. So what does this mean? Well, that means that the test with a specificity of 80%, you will identify 80 cases out of 100 without the disease. Okay. Now, another observation is that, again, for every 100 people that are disease-free, and you test them, 20 of those patients will trigger a false alarm. Remember, specificity is about false positives. So the larger your specificity is, the fewer false positives you have. So you want a test with high sensitivity and high specificity. Very rarely is a test both of those. Sometimes you have to have a test that has high sensitivity to rule out a disease, but if it comes back positive, then I need to go over and do a highly specific test to verify it sometimes. Now, I mentioned the word accuracy, and if you haven't seen the lecture on precision, which is also referred to as reliability, and then accuracy is that trueness. But it's a formula. You calculate it. Okay, and I show you that formula here. I've showed you the numbers and why you need that third column and third row, because you need the total number of samples, which in this case is 200. So the formula down here is the total number of samples on the denominator, and that is divided into the total true positive and true negative. How accurate is this study? And you see that the result is 0.85. Okay? And that is how accurately it reflects the true results, especially when you compare it to the gold standard. Okay? So remember, high sensitivity SNOUT, this is best for screening and ruling out disease when suspicion is low. A negative result, disease is unlikely, that protects you against missed diagnoses or delayed treatment. High specificity or SPIN, remember ruling in, that's best for when you're confirming disease when the suspicion is higher or after you've had a positive sensitive test. So a positive result, the disease likely protects against false alarms, unnecessary cost, anxiety, those labels and things that we talked about. Okay. So our common real-world strategy is that, like I said, you start off with a highly sensitive test to screen or rule out. But if it's positive, you've got to go on to typically another step in most cases with a highly specific test to confirm or rule in. Let's think about the D-dimer test. So it's a good sensitivity test when it's age adjusted, okay? But if it's positive or elevated, it doesn't give you the actual diagnosis. You have to go on and do a more confirmatory test that has greater specificity. And in this case, that is a CT angiogram of the pulmonary artery, basically, to look for a presence of a PE. So that's why we use the D-dimer, because if it reaches a certain cut point or threshold, we now have an elevated number that's positive, but it doesn't guarantee me that it is a DVT or PE, because there are other things that can elevate the D-dimer. And so this matters in everyday clinical decisions that we make, because it helps us to choose the sequence in a logical, clinically relevant format for the patient in front of us. You don't want to over or under react. Okay, and we want to reduce both the underdiagnosis and over treatment of patients that's inappropriate, because you expose them. Okay. Now, some limitations, okay? Now, these are previews for other topics in the series. Limitations of sensitivity, specificity. They describe the tests, the individual test's performance in a known population, okay? They do not, guys, directly tell you the probability your patient has the disease. That requires the calculation of the predictive values and the likelihood ratios for that test. And I'm going to cover those in another lecture, okay? So why don't we just use a single test that is 100% sensitive and 100% specific? I've kind of said that a couple times. It doesn't really exist. Why not? Well, because biology isn't binary, isn't it? Biomarkers and these test values often overlap between healthy and diseased patients, and we got to figure out where that cut point is before it becomes a problem. We all make D-dimer, every single one of us, every day. We're in this balance of preventing ourselves from clotting all over the place, but also from not bleeding everywhere. So we have cells that turn over, we have activity that's happening, and we measure it, and all of us have D-dimer present in our bodies. But there's a certain threshold that we get to, and that's where we, as we increase the test sensitivity, guess what? We'll capture everybody with the true positive, but it will lower the specificity in doing so, because you'll increase the false positives by doing that. And this becomes that seesaw effect that I was referring to earlier. You sacrifice one thing to gain something else. And that's why many times you need those two tests. And in an example of working up somebody for PE, I may do a D-dimer if I'm not entirely sure, but when it comes positive, I can't say, oh, you have a PE. I have to do the imaging, or you have a DVT, I have to do imaging to prove it. If we want to increase the test specificities, ensure that there's no, remember, false positives. Well, if we do that, we raise the threshold, well, then we'll inevitably increase the false negatives, and that will lower our sensitivity. So sensitivity and specificity operate in this seesaw effect, okay? Adjusting the test to improve one almost always compromises the others. This is the battle that's happening, and why guideline committees or researchers do ROC curves, okay? And calculate AUCs or C statistics. They help guide us in that cut point. It's not perfect, but that's why you need to know that it happens. You may not be the one doing it, but it happens. Now, other things to keep in mind, right, is that sensitivity, specificity, again, do not provide that predictive property of the disease. They are only properties of the diagnostic test, right? And in that test in the known population. They ask, sensitivity, specificity asks, if I know the patient has the disease, what are the odds the test is going to be positive? The clinician will ask, if the test is positive, what are the odds that my patient actually then has that disease? You see the two questions or angles that we each have. And that's okay. You just need to keep yourself oriented. So the take-home points are, you cannot use specificity and sensitivity alone to make a final diagnosis, usually. Okay, to answer the clinician's sort of question, we've got to look at that next step. That's the negative and positive predictive values, or the incorporation of the use of likelihood ratios that change our pretest probability and or change the pretest probability to our post-test probability. Whew, that's a lot. I hope that helped make some sense of things. Sometimes this is one of those topics you have to listen to more than once. You have to let it set in, soak in. Maybe we have to read things. Again, we've got charts, tables, things for you available at thisiswhy.health. But remember, this is just one episode in a series of topics in our playlist on diagnostic tests that's part of a larger collection on biostatistics and clinical research. So if you need help with that, or you need the other pieces, I would strongly encourage you to continue to dive into this and not give up, okay? This is worth the investment. Over time, it starts to stick and starts to come together. So thank you so much for joining. I'm Dr. Busti. I hope that you found it helpful. If you haven't subscribed, please give that consideration. If you want to leave a comment, we would value that. Share something, experience, and knowledge, perspective. It's hard to cover everything in one thing. We all learn from each other. But we would definitely appreciate that. You also may be giving us a like. Those things support the channel and allow us to continue to do what we are doing for you. So thank you so much, and we'll see you next time. Take care.